Everybody, welcome. Thank you for joining us today. We're excited to present to you information about pancreatic cancer from our specialists here at Weill Cornell. And the reason for this webinar is because, as you know or may not know, November is Pancreatic Cancer Awareness Month. And we want to let everybody know what the facts about pancreatic cancer, educate people, have people learn about the genetic implications of the disease, as well as research advances and procedural information about the diagnosis. So that's what we're going to be discussing tonight. We're going to have time at the end for questions. The reason why we're all here tonight is because we all have been touched by pancreatic cancer, whether it's personally, through a relative, through a patient. This is a disease that is close to all of us. So we all want to make sure that everyone has the latest information about the best treatments, the best research that's going on. And we want to, the more people we educate, the more it's just better for awareness, for research, for raising dollars for research, and obviously for getting all this information into the hands of the patient. So thank you all for attending tonight, and especially thank you to our patients who have joined us, and I'll introduce them later on, but let's get started. Our first presenter is Dr. Rohit Chandwani. He is one of our amazing pancreatic biliary surgeons. And I'm going to turn it over to Dr. Chandwani to say more about you, and then take it from there.
Thank you, Dr. Ocean. Much appreciated. It's a pleasure to be here. It's a pleasure to have the opportunity to talk to all of you about my work in pancreatic cancer. As Dr. Ocean mentioned, I am a pancreas and liver surgeon. I've been here at Cornell for the last 5 years. I went to medical school a long time ago. I did my residency in surgery at Columbia, uptown, and then I took a little detour and did my PhD and basic science training at Rockefeller, and did my postdoctoral and clinical fellowships at Memorial Sloan Kettering. And then in 2017, I came here. As Dr. Ocean mentioned, I am a surgeon. I will not be talking about any of that today, and so I'm happy to take questions about pancreas surgery later on. What I will be talking about is the thing that I spend a lot of my other time doing, which is running a basic science laboratory that is largely focused on pancreatic cancer. Today, I'm going to talk about my research and what we are doing that represents advances in our understanding of the biology of pancreatic cancer. Because I'm going first, when we talk about pancreatic cancer, we're talking about pancreatic ductal adenocarcinoma. There are other cancers of the pancreas that behave very differently, and that really don't apply in terms of the outcomes and the biological difficulties that we face with pancreatic ductal adenocarcinoma. It's soon projected to be the second leading cause of death. That should say 2030, and the survival remains quite poor at 10% at 5 years. And you can see that it lags behind many other tumor types. And so Francesca is going to be talking about this later, about the components of pancreatic cancer that are hereditary and what those genetic determinants are. But the vast majority of these cases are sporadic. And what we've had is a hard time identifying people who are at significant risk of developing this disease, and of developing screening tests and identifying that right population in which to apply those screening tests. And so no single risk factor really identifies a large enough population to capture really a significant proportion of disease. And importantly, pancreatic cancer is largely a disease of acquired mutations. And so briefly, what are the genetics? Summarizing 20 years of work in the the end of the last century, with pathologists doing lots of staining of slides of pancreatic cancer, identified most of the clear genetic determinants of this disease. And as you'll see over on the left is KRAS, which is mutated in 90% of pancreatic cancers. Significant work thereafter has leveraged the revolution in sequencing technologies to identify several of the different genomic events that are occurring, to where we now have this map that shows us the entire mutational landscape of pancreatic cancer. But all of that is basically reduced into a number of genes, beginning with RNF43 here, all the way to the bottom, that are mutated in less than 10% of the cancers, and 4 genes that are mutated much more commonly than that. And those 4 abundantly mutated genes are very difficult to target. And as I said, everything else does not capture a significant proportion of the population. And so several of the advances that we have in treating patients with DNA repair deficiencies, or patients with specific mutations in BRAF or in HER2, have been difficult to leverage on the pancreatic cancer population. And in addition, where we see that there are high response rates to immunotherapy, correlating with the mutations, pancreatic cancer is way down here, having very few mutations and therefore being quite difficult to treat with immunotherapy. So some of the many advances, as I said, that we have in treating cancer have been hard to leverage into the pancreatic cancer space. My simple way of making this point is that, and this is for the, hopefully no one here studies leukemia or lymphoma, but they have an easy problem. They have cancer cells that are floating around in the bloodstream. By contrast, the pancreatic cancer consists of significant rewiring of its local environment, of cells that are hard to get to, much less treat. And what that creates is a problem not just of drug delivery, but of finding dependencies for this cancer that was born in a harsh environment. And by being born in a harsh environment, these pancreatic cancer cells are highly adapted to survive in any condition. And that makes them difficult to eradicate. So where do we go from here? So I'm going to talk briefly about many of the things that we've been doing in my laboratory to understand better the biology of pancreatic cancer and how it can be leveraged into therapeutic opportunities. So early models of pancreatic cancer applied mutant KRAS broadly in the pancreas. And I'm going to go through these slides very quickly in the interest of time. But we now have very specific and highly reproducible models of pancreatic cancer where we can trace specific cells as they undergo the transitions to tumor. Excuse me. And what we've learned from many of these models is that there's a lot of changes to signaling, the communication between proteins within a cell. There's a lot of reprogramming of how pancreatic cancer cells engage in metabolism, how they use their nutrients. And we've learned a lot about the microenvironment, how pancreatic cancer both rewires its local environment and how it leverages that environment to get the nutrients that it needs to continue to grow. And so we've learned a lot about what these dependencies might be among these cells from these models that I mentioned. In my laboratory, we study something very specific. We're adding a 4th box, if you will, to that last slide, where we try to understand what are the epigenetic liabilities. And when I say epigenetic, I mean the context in which DNA is found. DNA is not just naked in the cell, it's wrapped around histones, around proteins, and it's organized highly within the nucleus. It's compacted in something called chromatin, and that chromatin interacts with each other, and different histones can be utilized. Those histones can be modified. The DNA can be used in a variety of different ways and can itself be modified. And so what we do is leverage this understanding of the epigenome to understand some of the dependencies of pancreatic cancer. And we do that because what makes cells different from one another, what makes neurons different from the cells in your GI tract, different from your blood cells, are the features of the epigenome. And this basically summarizes how, if you look at a bunch of different cell types in the columns, what makes them different is their epigenome, not the DNA itself. And so understanding how the DNA is packaged is important. So what have we learned from studying the epigenome of pancreatic cancer initiation and tumor progression? Well, we've understood now that inflammation is important for the development of cancer. And I won't belabor the point, but we've used sort of complex mouse models to identify how the epigenome is hijacked in the development of cancer. And I'm going to go through this fairly quickly. And to identify a transcription factor called AP1, as we and many others have shown, to be a liability of these tumors, meaning that it is required to reprogram the epigenome, to change how chromatin is structured. And we've now shown for the first time that when we take away KRAS, that recapitulates what happens when you take away this same transcription factor, showing that tumors that are dependent on KRAS are also equally dependent on this transcription factor. So we've now turned something untargetable into something that's now targetable. We've also shown in recent work where we've leveraged the fact that we know that inflammation is important to ask, well, does inflammation and the development of a RAS or a KRAS mutation, do they have to happen at the same time? And what we've learned is that they don't. That we all in our differentiated in the epithelial cells of our pancreas have the capacity to retain a memory of even a transient inflammation, which is why I'm not going to go home and have 3 glasses of wine, because my pancreas might remember the pancreatitis that I have from drinking too much. But what we've learned is that if even the transient inflammatory insult can conspire with the later activation of mutant KRAS to drive the development of a cancer, at least in our mouse models. And this helps us understand that it may be the case that patients who even have no history of active chronic pancreatitis have a risk of developing cancer. And that allows us to have the opportunity to now interfere with that memory that accumulates from having subclinical pancreatitis years before into something that can be targeted. Other work that we're doing in the laboratory is understanding how different mutant KRAS alleles are different from each other. There are many different mutations that can occur in KRAS, and we're articulating together with our colleagues how these different mutations function differently and reprogram the epigenome in different ways. And this is work that has been done by Luke Dow here at Cornell, as well as others, highlighting that the G12R mutation has distinct biological consequences from the other mutations that are found in pancreatic cancer. In work from my lab, we've also been trying to understand what are the important mediators downstream of KRAS that are targetable. What does KRAS itself depend on in order to maintain a tumor? We know that KRAS mutant tumors depend on KRAS. Without that mutation, those cells die. But in the absence of being able to target KRAS, how can we leverage the dependency on KRAS? And so what we've done is look at all of the different effectors, all of the different molecules that KRAS interacts with, and asked which of these is important. And I won't belabor the point, but we've found basically that RAC1, one of the effectors of KRAS, is much more important than the other. In the absence of RAC1, cells die. Our organoids, and even our organoids that are derived from human patients, appear to be very clearly dependent on the presence of RAC1, which you can see here is indicated by the fact that they're just as small and just as absent as KRAS depleted organoids. In addition, when we deplete tumors of RAC1 in a mouse model of tumors, those tumors are smaller and the mice live longer. And finally, we show that RAC1 and have found that RAC1 correlates with survival in the human setting. So to summarize, the epigenetic memory of inflammation can substitute for contemporaneous inflammation. And we found that reprogramming of the epigenome is dependent on a specific transcription factor. And all of that work is essentially trying to identify what are the dependencies that exist outside of KRAS itself that we can indeed target. Different KRAS mutations are important, and that the malignant cell fate depends specifically on the continued function of RAC1. So we've learned that there's more to phenotype than genotype. So the genetics are not just all of what determines what a pancreatic cancer is, how it will behave, and the outcomes that patients have. That more layers of cellular characterization refine prognostication, and that we're now more accurately able to model the tumor and define its vulnerabilities. And finally, I hope you come away with the message that epigenetic studies can define new vulnerabilities in pancreatic cancer. So with that, I thank my lab, and I'm happy to take questions at the end, as well as acknowledge the funding sources that have supported our work over the years.
Dr. Chinwani, that was awesome. I learned so much too, and I have some questions that I'm gonna ask you later. Thank you. For those of who joined us just recently, this is a webinar that we're doing in honor of Pancreatic Cancer Awareness Month. I'm Dr. Allison Ocean, and our next presenter is Dr. Despina Ciolis. She is my colleague and my friend, and she is a pancreatic cancer clinician and researcher. She joined us recently from NYU, and I'm gonna turn it over to Dr. Ciolis to tell us about treatment updates for advanced disease and clinical trials. Thank you, Dr. Ciolis.
Thank you, Dr. Ocean. So hi, everyone. My name is Despina Ciolis. I'm an assistant professor here at Cornell. I joined a year ago. Just like Dr. Ocean, I'm a medical oncologist, and I recently came from NYU, where my specialty was pancreatic cancer. Tonight, I'm going to be talking about clinical management for patients with pancreatic cancer. And so I'm going to talk about what the purpose of systemic therapy is, what are our current options, and what are some clinical trials available at Cornell. So I just want to hit some of the most basic facts so that I make sure that we're all on the same page. So within the last decade, pancreatic cancer is expected to rise to become the second leading cause of cancer-related death. And the vast majority of patients, more than 80%, are inoperable at diagnosis. However, chemotherapy offers the ability to treat patients who have multiple disease sites at once because it's systemic. It goes through the blood. Now, so when is chemotherapy used? Well, it can be used after surgery to eliminate microscopic disease, or it can be used before surgery to downstage or shrink a tumor in order to facilitate an easier operation. If a patient has multiple tumor sites, like in a stage 4, chemotherapy is often given to try to control all the sites of disease. So if we focus on patients who are stage 4 and have multiple sites of disease and look at the systemic therapy, I just want to give a little bit of history to put things into context. In 1997, gemcitabine was the first chemotherapy approved for patients with stage 4 pancreatic cancer. And over the following decade, multiple gemcitabine-based combinations were evaluated with no clear regimen. However, in 2005, gemcitabine and erlotinib was approved, but there was a very modest improvement in patient survival, one of almost questionable significance. So, and because of the side effects associated, we really don't use this regimen in practice anymore. However, within the last decade, 2 different chemotherapy regimens, multi-agent regimens, were approved for pancreatic cancer. One is called FOLFIRINOX, which is an acronym for a combination of drugs. and that became approved in 2011. And another combination, gemcitabine with nab-paclitaxel, was also approved for first-line treatment. And there doesn't seem to be cross-resistance between these two regimens. However, although each regimen was, when the clinical trial was conducted, demonstrating efficacy, it was compared to single-agent gemcitabine for both regimens. But the patient population wasn't exactly the same, both in terms of tolerability, or as we call performance status, side effects, and also patient number. So because of this, we don't really know which regimen works for which person. And when a patient comes into the office, they want to know, will these drugs work for me? So this gives us the opportunity to perform a clinical trial. So I just want to take a step back and say that clinical trials are research studies that are performed in people that are aimed at evaluating a medical or surgical or behavioral intervention. They are the primary way for researchers to find out if a new treatment or a new drug is safe and effective. So clinical trials at academic centers like Cornell give us the opportunity to expose patients to new therapy or new types of treatment. There's no guarantees that the new treatment will work, but it's necessary to perform clinical trials in order for the field of medicine to progress. And the purpose of clinical trials is not to make people into guinea pigs, but rather to evaluate new drugs or methods, surgical methods, in a safe and controlled manner with extra attention to side effects or other interactions that may occur. So as I mentioned, we don't really know which patients FOLFIRINOX or gemcitabine and nab-paclitaxel will work in. And so this gives us the opportunity to do a clinical trial. And the first clinical trial I want to highlight is called Precision Promise. This is a trial that's sponsored by PanCAN, which is a national patient advocacy group. And it's for patients who haven't been treated before, but have stage 4 pancreatic cancer. And they get randomized to either gemcitabine and nab-paclitaxel or FOLFIRINOX, or an experimental arm that I'm going to talk about in a second. But why would we do that? The purpose is to determine which therapy works best for which patients. Now, because this clinical trial is sponsored by a patient advocacy organization, they also include some other details, which are very interesting. The first is a research biopsy that allows us to look at the DNA, RNA, proteins in the tumor that may be biomarkers for predicting treatment response. Another part of this trial is that it also includes a Fitbit. So the Fitbit is optional for patients who don't want to wear it, but the purpose is to track things that are such as sleep, activity in patients. And it's because patients think sleep, and physical activity, being able to, walk around, have energy to do things is important. And often these things are overlooked by pharmaceutical companies who are more interested in efficacy. But because this is a physician-designed trial with patient advocates, we think that these kinds of things are also important to keep track of. And this national trial actually was first started in 2019. And I was the first, this is a trivia fact, I was the first physician to put a patient on this trial back when I was at NYU in 2019. So certainly we're gathering a lot of information about it. Now, what happens if a patient has already been treated? So in addition to having a first-line arm, there is a second-line arm. So if you haven't been treated, you may be randomized to this arm. And if you have already been treated at an outside site, you still may be able to receive this drug combination, which is considered investigational or experimental. which is a combination of gemcitabine and nab-paclitaxel together with pamrevlumab. Pamrevlumab is an antibody that binds to connective tissue growth factor protein. And the idea is that it would break down fibrosis or protective cells around the tumor. It's actually being used in lung fibrosis disease. So this is an interesting drug, and we're actively recruiting for this trial at Cornell. But what about treatment for patients whose tumor may be too extensive for surgery, but don't have metastasis? So a patient who is not initially a surgical candidate and their tumor doesn't have metastatic sites is considered locally advanced. And we have a trial for these type of patients, which is a phase 2 study of peposertib in combination with radiotherapy for the treatment of patients with locally advanced pancreatic cancer. Now, for patients, these are for patients who have tried standard chemo and their tumors have not decreased in size, and so they want to try something that's investigational or novel. And peposertib is an oral pill that inhibits an enzyme that's involved with DNA repair. Similar, and in preclinical studies, peposertib has been found to demonstrate synergy by with radiation by preventing the repair of radiation-induced DNA breaks. So the radiation causes DNA breaks, peposertib inhibits the enzymes involved in DNA repair, and the idea is together they would work better, synergize than either one alone. So this is another trial that we're doing at Cornell. So what about immunotherapy? Everybody wants to talk about immunotherapy. It's fascinating, but unfortunately, doesn't work. Single agent immunotherapy, the type you would see in melanoma or lung cancer or some other cancers, does not work in pancreatic cancer. And most trials of chemotherapy combined with checkpoint inhibitors isn't more effective than chemo alone. So this means we need to try a different type of immunotherapy or a different type of combination. And this is a really fascinating study. It's a study that's going to be led by Dr. Ocean, and it's called Quilt 88, which is an experimental cancer vaccine. Now, as you could see by this blue box, it has a complicated schedule, which is very difficult to summarize in one slide, but I will do my best. So it's a phase 2 study of combination immunotherapy plus chemotherapy and radiation for patients with locally advanced or metastatic pancreatic cancer. Now, we're not giving everything at the same time, but rather it's an orchestrated approach of low-dose chemotherapy that is spread over time, combined with radiation. And in terms of the immunotherapy, there's an immunostimulatory IL-15, it's called superagonist, and a PD-L1, that's a type of immune cell, targeted natural killer cell, that's another type of immune cell, infusion. So the hypothesis behind this orchestrated approach is that by revealing tumor antigens to the immune cells, meaning that we're exposing the tumor to your immune system, we can activate tumor-specific T cells and targeted natural killer cells, which is the natural killer cell infusion, to eradicate or kill the tumor by what is known as immunogenic cell death. And this comes from Patrick Soon-Shiong, who is a very prominent bio entrepreneur. He actually was one of the discoverers of Abraxane, nab-paclitaxel. And so it's fascinating to see what will happen. And this is really exciting, and it's going to be opening soon. So then finally, what about the future? We talked about what's currently available, what we're investigating now, but what's going to happen? Where do we see things going? And so I want to give my perspective as a cancer doctor and a cancer researcher. So one of the things that I'm researching is a unique feature of this disease that Dr. Chandawani also talked about, which is the tumor microenvironment. And these are, specifically, I'm focusing on the immune microenvironment, which are the immune cells that surround the tumor. And the immune cells that surround the actual tumor and are interweaved in between the cancer cells can contribute to tumor growth and also therapy resistance. So some of the questions that I'm answering in my research lab is, does the components of the tumor microenvironment differ among tumors with different DNA or genotypes? And can we design more precise therapy regimens that include immunotherapy for patients based on their tumor's DNA? And I'm really excited to share that my lab website has gone live, so you can learn more about the things that I study at this link. So in conclusion, combination chemotherapy remains the standard of care for treating pancreatic cancer patients with advanced disease. And clinical trials are underway to determine if personalized drug regimens can be applied for patients. Also, we're trying to understand new therapy combinations and what are the side effects of these new therapies. And I'm really excited for you to learn more about the research that I'm conducting at this website below. And if anyone is interested in doing research, there's opportunities to get involved as well. Okay, thank you very much, Dr. Ocean, and I'm going to turn it back to you.
Thank you, Dr. Seolis. That was awesome. I'm now going to introduce to you Dr. Reem Sharaya. She's been at Cornell for a long time, maybe as long as me. I can't remember exactly, but a while. And she's very hands-on and spectacular with procedures. And she's going to talk to us today about management of common issues and complications in pancreatic cancer and endoscopic innovation. So Dr. Sharaya, thank you so much, and excited to hear from you.
Thank you so much for the invitation. So I'm going to be talking a little bit about what we can do with an endoscope with patients who have pancreatic cancer, either from a palliative or therapeutic perspective. And so where does endoscopy fit in with the care of a pancreatic patient with pancreatic cancer? So either with an endoscopy for diagnosis through ERCP or via endoscopic ultrasound when we do fine needle aspiration or biopsy. And we do biopsy, so you can get a fair number of cores with that. Or we use it for palliation, so for stenting, for enteral stenting, or for pain management by doing celiac neurolysis or block, for biliary drainage, or by doing an endoscopic gastric bypass. And very new is more of the anti-tumor therapy that I'm not really going to focus on because there's not that much data out there long term. So hopefully we'll take you on the frontier for endoscopic innovation. So we do fiducial therapies or spacer injections for pancreatic cancer, although more and more lately, and especially at Cornell, we have the SMART MRI that probably negates from doing that. And so let's talk about what we can do. So fiducial therapies are basically gold markers that are placed through the endoscopic ultrasound into the tumor itself, so that when you go in and do radiation, you can get real-time targeting for the location, and you decrease toxicity to the tissue. And so in a meta-analysis of 14 studies, the technical success for placement of fiducials, which you can see here, was 98%. Migration was very low, and adverse events were also very low. There was mild pancreatitis in 4 patients, but no life-threatening events. And here you can see the fiducials. So the conclusion for this is that fiducial markers are safe and effective, and if you need them for placement, we can do that. What about acquisition of portovenous sampling for tumor cells? So this is sort of a fairly new field that we're in, but basically you can access circulating DNA from the portal vein via US. And so here you can see cases of confirmed pancreatic cancer. You can see the circulating tumor DNA is much higher in the portal system than in the peripheral, and it can also make a difference between resectable and unresectable patients. Again, this is very early data. This is a publication from University of Chicago, which we partner with a lot, and you can see that this is just small numbers. So we need more data for this, as I mentioned. So what about ablative therapies? So we know from IR you can use radiofrequency ablation or cryotherapy or photodynamic therapy. And you can do the same thing for patients with pancreatic cancer. You can either do chemical ablation with alcohol or cytotoxic agents, or we can do RFA, so radiofrequency ablation, stereotactic, or photodynamic therapy. And newer data, as yet, you can do chemotherapeutic agents and viral injection of viral vectors. So the new RFA probe is via StarMed, which is from Korea, and you can access the tumor itself. And then it basically, depending on the size of the needle that we use, you can do ablation of the tumor itself. It's very well studied in neuroendocrine tumors, as I'll show you in a second, but here's a video for this where you inject the needle. And then you do the ablation, and you can see sort of heat that can happen, coagulative necrosis at the same time. And this is this is an old study, but it's been studied for pancreatic cancer in a small number of patients, where you can see the use of RFA probe improves survival with the addition of chemotherapy. This was a small study back in 2016. But about 2 weeks ago at ACG, there was a larger data trial that was a randomized study that looked at RFA plus chemotherapy versus chemotherapy alone. And in about 30 patients, they showed a small improvement in survival with the patients that had RFA. So the take home is that it may play a role in patients unfit for surgery or local control for palliation, but we need longer and larger prospective studies. So for EUS-guided pancreatic adenocarcinoma, you can either have therapies that improve survival or therapies that cause palliation. And a lot of the ablative therapies probably are more palliative. You can have celiac plexus neurolysis that can improve pain, fiducial therapies, as I mentioned. Brachytherapy I didn't touch upon because it's very small data. We're only talking here for 10 minutes, but there's very interesting data on that. So similar to what we do with prostate cancer, you can also do it with pancreatic. And then you can do injection of chemotherapies or immunotherapy. Again, this is potentially very effective and safe, but long-term data is needed. And so there's a lot of exciting fields where the EUS can take us. How about drainage? Well, we know we do ERCP for the majority of patients who present with jaundice or obstructive LFT picture, but it can fail in about 5% of cases. So we do, as I just did right now, EUS-guided biliary drainage into the duct itself. So it mitigates the need from using IR drainage. So you can have internal drainage through the stomach or through the pylorus. And you can see here's an internal stent, and the patient doesn't have to have a PTC drain from the outside. And this is a video showing this. So this is the common bile duct, which you can see. You access it with a needle and pass a wire. and then you deploy a lumen opposing metal stent into the common bile duct. As you can see here. And so patients do really well with this. They like it, they have less pain, and it's a procedure that can be done at the same time as a ERCP if the ERCP fails. What about symptom management? So we can do both for gastric outlet obstruction or for pain. So EUS guided gastroenterostomy or gastrojejunostomy is essentially an endoscopic bypass, which we can do. So this is a patient of ours that was referred from an outside hospital that had multiple duodenal stents and tumor. By putting in a lumen opposing metal stent from the stomach directly into the distal duodenum or jejunum. And so you can see here, they go home the same day. And the advantage over surgical bypasses is that you don't have to stop chemotherapy and the patient doesn't have extensive length of stay. And so this was a comparative study between EUS gastroenterostomy versus a laparoscopic gastroenterostomy. And this was retrospective, but ongoing prospective trial is currently underway. You can see here that the technical and clinical success are similar between the two groups. The procedure time is much shorter with the endoscopic approach. Oral intake, hospital stay, and adverse events are also much less and all statistically significant, sort of suggesting that for patients who need a bypass, that you can do an endoscopic bypass for them. And this is comparing the endoscopic bypass versus the sort of classical duodenal stent. What you can see here is that with the endoscopic bypass, because the stent is shorter, you get less obstruction. So the conclusion, duodenal stents are good, but EUS is an exciting, expandable, expanding field. GJs is promising, but it's a technically challenging procedure, and in expert hands, we can use it. And so lastly, I wanted to talk about celiac plexus block. We can inject either ethanol into the celiac ganglion itself. This has been done since the 1990s, which now seems like a long time ago, but it has a success in about 74% of patients, so similar to what you would get with interventional endoscopy. And RFA we talked about. And finally, I don't know if I have a little bit of time, but just to talk about RFA and PDT, which is what we do through with ERCP. You can basically, when you're doing an ERCP, we can offer radiofrequency ablation into the bile duct itself, and that minimizes tuber ingrowth, overgrowth. And in a small study that we did, it shows improvement in survival in a small number of patients. I'm going to skip the video for the sake of time, but here you can see we compared our data for pancreatic cancer with the SEER database, and you can see here there was improvement in survival with those patients. It's a small study, but ongoing prospective data is out there. So thank you very much for your attention, and looking forward to answering any questions.
Thank you, Dr. Shariah. That was great. We're definitely going to ask you about some of these procedures, because we know that our patients frequently need to have these procedures done, and we thank you and your team for always being available to help the patients. Okay, next. We have Francesca here, Francesca Tubito. She is our genetic counselor, and I want to thank Francesca for coming tonight to tell us all about what we need to know in 10 minutes for genetic testing in pancreatic cancer, and talk about some of the hereditary links in this disease. And thank you so much, Francesca, for joining us tonight.
Thank you for having me. I will try to keep it short and sweet, but I'm Francesca. I'm a genetic counselor at Weill Cornell. I've been here for almost a decade now, and I subspecialize in gastroenterology and pancreatic cancer. All right, so I think Dr. Chandwani started off with some of this, but like all cancers, pancreatic cancer is usually not due to a genetic predisposition, and these are some of the better known contributing factors that we think can lead to pancreas cancer. So age or time, having a family history. Of course, there are some genetic predispositions to pancreatic cancer, a chronic history of pancreatitis or hereditary pancreatitis, smoking, obesity, and chronic diabetes. So this chart is showing, okay, let's say this is all pancreatic cancer diagnoses. Most of them, like Dr. Chandwani mentioned, are sporadic, meaning that they're due to something listed on the previous slide. Only about 6% that we know of now are due to a known genetic predisposition, and 10% are familial. So the practice of genetic counseling in pancreas cancer has evolved quickly over the last couple of years, and usually we would only see patients that are in the smaller part of the chart here to have genetic testing. But recently, in the last couple of years, we are seeing all of the patients with pancreatic cancer to rule in or probably rule out a genetic predisposition. And why is that important? So when we want to do genetic testing for pancreatic cancer, there are a couple of benefits. So one, like Dr. Cialis was going over, there are some personalized treatments, and we hope to develop more in the future, but there are some that exist now, and we have some really great outcomes for some patients who do have genetic predispositions to their pancreas cancer. There are some treatments that are very specialized and work well. If there's a person who does not have cancer at the moment and we're doing predisposition genetic testing, we can make a personalized cancer risk assessment with the information that we gain. If they do have a genetic predisposition to pancreas cancer or other cancers, the goal of knowing that information is so that we can do early and increased screening for the early detection of the cancer, because all cancers are much more easy to treat if you catch them early. And the last reason would be not for you or the person that we're testing, but for family members. So if there is a genetic predisposition to cancers, it's genetic. So you can identify at-risk relatives before they ever develop a cancer. And this way, again, they would have the opportunity for the early detection and prevention of cancers. But then genetic testing is voluntary. It's not just like another run-of-the-mill test. The patient has the choice whether they want the information or not, and they don't have to have it. Most patients do choose to undergo the test, but some things to consider. Again, some of the benefits are information for your family members, early detection options. There are risk reduction options for some of the other cancers that can be associated with pancreas cancer in these syndromes. And relief, because if you test negative, actually, then you know you're not at higher risk for another cancer or a different cancer. Some things that might hold patients back from testing are the possibility of an insurance discrimination. They might just be worried about how they'll feel about themselves moving forward, or their family will feel about them, or people will be mad at them for it, and stigma and fear. And then survival guilt. So sometimes when there's a genetic predisposition in a family, the people who test negative actually have a hard time dealing with that because they feel like they're not deserving of not having inherited that familial mutation. So there are things to consider on both sides of the spectrum. So how do you decide? So there is genetic counseling, and it is a process by which somebody like me or Dr. Ocean or a doctor that feels comfortable would counsel you and your family members, and they'd help you go through the diagnosis that you have, any psychosocial factors associated with that, and other implications for your relatives. And they would do that by taking your medical history, your family history, and coming out with a risk assessment to let you know how high the chance they think that you do have a genetic predisposition is, so you can use that information in making the decision of whether or not to go through with the testing. They are trained to provide the information to you in a way that you understand and use more layman's terms than medical terms. It's non-directed counseling, meaning that you have the choice as to whether or not you want to go through with the testing. You don't have to. And then there's full informed consent. So knowing the benefits, risks, limitations, and things that could come down the line before you decide to do the test and not afterwards. So there are a lot of possible outcomes with genetic testing. It's not so positive or negative, but with genetic counseling, you have those results given to you with interpretation. So what do they mean for you and your family? We would go over a personalized cancer risk assessment for you then, using your medical history, your family history, and now the genetic test results. We're able to give you a personalized risk assessment moving forward for all of the cancers that you might be at risk for, or none of the cancers that you might be at risk for. We can make medical management recommendations. For those that are of reproductive age, there are options if they do test positive for a genetic predisposition to cancers, if they wanted to prevent passing that on, or if they just can have the information of what's the chance that they pass it on and how will it affect a future child. Genetic counselors can connect to patients with valuable resources like patient advocacy groups. We would go over the implications for your relatives, and we would have a discussion of how to talk with your relatives about this information, because it's not always so easy, because it affects them as well, or can affect them as well. It's not just about you, the information that you're giving them. We answer lots of questions, and then, of course, comes along the psychosocial counseling for the people who have certain feelings that they can't help that come along with whatever their test results are. And so to wrap up, the most common hereditary predisposition to cancer, to pancreas cancer, is hereditary breast and ovarian cancer syndrome, or HBOC, and the gene that causes the most hereditary pancreatic cancer is BRCA2. And so this is just an example of one of the syndromes that people can have that causes them to have a higher risk to develop cancer than someone else. And this condition causes a significantly increased risk for breast cancer, ovarian cancer, prostate cancer, and pancreas cancer. So if they're coming in just because they have pancreas cancer or a family member has pancreas cancer, you can see that there's more implications for them than just pancreas cancer. So there's a lot to consider when they're deciding to have the test, and a lot to deal with if they end up testing positive. This condition causes young age at diagnosis for these cancers. The cancers progress more quickly than they would have had the cancer originally been sporadic, which, as a reminder, most cancers are sporadic and not due to a condition like this, but when they are, they grow a little bit more quickly. People can have more than one cancer diagnosis when they have these high risks, and you do see a familial pattern going through, well, the cancers being diagnosed in family members, and there's a pattern. Also, even though the cancers can progress more quickly than in the sporadic cases, like I mentioned earlier, there are some treatments that are more specialized to target these types of cancers that work pretty well. And I think those are all of my slides, so we can move on to the patient portion.
Thank you so much, Francesca. That was great. And now I'm gonna open it up to our guests tonight who have graciously offered to tell their stories and about their journey with pancreatic cancer. And thank you so much for being here with us, to Malky and to Carlos. Please feel free to share whatever you want to share. And I can start it off, Malky, first. If you could unmute, please. Okay. Welcome. Thank you so much. If you feel comfortable, I wanted you to, you just heard a lot about the disease, genetics, all this stuff going on. when did you know about all of this, or did you learn it along the way? When did you know about all the stuff that we were talking about? Did you feel like you had to learn it fast? Tell us a little bit about your story.
I learned everything along the way. My father had pancreatic cancer. I never knew it was hereditary. I had some symptoms, and I went to my internist, and he sent me to Cornell, and he told me to look for Dr. Ocean. And they admitted me because I had a lot of fluid buildup in my stomach. And once they drained it and tested it, I was diagnosed with pancreatic cancer. But everything that I learned as I was treated. And I'd like to compliment Dr. Ocean for keeping me educated at every step of the way and explaining everything clearly. And I believe now I'm in a better place, and I've been, it looks like the treatments have been working to some degree, and I hope it continues.
Definitely. What, if it's okay to share, what I thought was fascinating about Malky's story was that right when she was diagnosed, we just got data that shows that every patient should be tested for genetic testing for pancreatic cancer, regardless of whether or not you have a family history. And when we did the testing, we did uncover something, and that something was very beneficial in your treatment, because we were able to introduce medicines that were targeted against that defect that we uncovered. And I think, and that was really the turning point, I think, for your treatment. And what I tell all my patients, and what I tell people who are asking me about pancreatic cancer, is that make sure that you tell your family history to your doctor, to your internist, even if it's a regular physical exam, like a well person visit, because the more people that know about diseases that run in families, like if your doctor knows about this, they know that there are some genetic syndromes that do run in families. And if you don't tell the information to your doctor, or if they don't ask it, sometimes they need to know, so that they can advocate and think of it as a potential diagnosis if someone comes in with a certain problem like weight loss or pain or something like that. So if they know that there's a family history of, let's say, pancreatic cancer or breast cancer or ovarian cancer or whatever, they may be thinking, oh, this is the BRCA gene, or this is something else. So that's what I think is important, that we know, that we tell our patients and tell everybody that be aware of your family history and genetics, even though that most cancers are not genetically related, as Francesca said, but we don't want to miss the ones that are, because it really matters for treatment. Malky, what pearls would you tell patients who are going through therapy now to things that you learned along the way?
The mind is a very important tool to help you get through it. To try and be optimistic, to try and live your life as normally as possible, even though it's very difficult. And do not ignore anything. In other words, if there's something that hurts or something that you see is not normal, don't ignore it. Do not ignore it.
Right, you have to be your own best advocate, always.
Correct.
That's true. Thank you so much for sharing, Malky. Really
Well,
appreciate it.
okay.
Carlos,
Yes,
thank you for joining us.
good to be here.
Thank you. Will you tell us about your story?
I was having breakfast about 2 years ago, and my wife asked me, well, how come my eyes were yellow? And then it started.
Mm-hmm.
So it's been almost 2 years. I've had a Whipple, and I've had a lot of chemo. I'm still having a lot of chemo. Thank you very much. Best advice I could give is try to live as normal life as you can. The disease and treatment are not any reasons for you to change your lifestyle drastically, unless you're unable to, of course. I have a couple of questions.
Absolutely.
For Dr. Chewani, can you starve the cancer cells of its nutrients?
So yes and no. So the cancer itself is really good at scavenging for nutrients. It can use pretty much any nutrient source that it finds available to it. And when I say that, well, I mean that one of the key features of pancreatic cancer cells is that they actually scavenge nutrients from the immediate environment. They basically engulf them. They can also induce nearby cells to engage in a process of cell death that delivers nutrients to them. They can digest the surrounding matrix, the collagen in it as a source of proline. So yes, they are obviously very dependent on nutrients, right? And because they're tumor cells that are, growing and proliferating, but at the same time, they can leverage a lot of different sources of nutrients. And so that can make it challenging. That being said, there are specific nutrients that, and I will say that cysteine is one of them, and glutamate is another, that they seem to be especially dependent upon.
Thank you. And Dr. Francesca, I get the impression that I should have my children and grandchildren screened. Do you agree?
You mean screen for pancreas cancer or screen for a predisposition to pancreas cancer?
Predisposition.
So we would like to start with the patient, because if you don't have a genetic predisposition to pancreas cancer, there's nothing that all of your descendants would need to be tested for.
I don't.
Then your relatives don't need to be tested, but they should let their doctors know that they have a family member who had pancreas cancer, in case they have one of the not yet discovered genetic predispositions to cancer, or there's just some familial component, so that their doctors have a little bit of a lower threshold to do a scan or something for them if they show up with symptoms that could look like pancreas cancer, because it's not always the first thing that comes to mind, a doctor's mind, when a patient comes in with like weight loss or jaundice.
Thank you.
What are some pearls that you want to give to patients going through therapy now?
What's been said before, be very aware of how you feel and how you're affected by either the disease or the treatment you're receiving. Because things can be changed, adjusted, etc. Because it's, to a large degree, I feel like it's a waiting game. Like currently I have no tumors. Great news. But what's happening next week? I don't know. Or next month? I don't know. Well, nobody knows. So you have to learn to accept that. That's the most difficult part, or was. I've been on this road for a while right now, so I've adapted.
That's right. You, by coming out here and sharing your story, you're helping so many people who are going to listen to this, because a lot of people don't like to talk about it, but thank you so much for sharing, because to both you and Malky, because it's really important that people know that you're living with this disease, you're getting treatment, you're finding quality of life in other things that you do, and that you can live a good lifestyle while undergoing treatment. And, you know, this, you were dealt a bad hand, of course, but we're doing our best to figure out ways we can control the growth of this cancer while maintaining your quality of life. And that's really the bottom line, that what we have to do as clinicians and what our researchers are doing to try to develop new therapies for you all. And I think there's a lot of hope on the horizon with all of the research that's going on. And I want to actually ask Dr. Chenwani, I had a question about his research. You were mentioning how RAC1 is a target for these cells. Is there a drug that can target RAC1?
Yeah, there are actually several drugs that target RAC1. You know, to my knowledge, they've not been investigated really in the human setting. They don't have great, you know, pharmacologic properties, you know, for dosing in humans just yet. But that's not to say that, you know, we're actually currently working with, you know, Sanofi to, you know, design, you know, better RAC1 inhibitors for the reasons that you articulate.
Oh, that's great, because we hear that KRAS is not druggable yet, or we're trying to find blockers to this KRAS protein, which is the most common growth protein causing pancreatic cancer cells to grow. And that's been really the challenge in research up until now. What are you most excited about in terms of these newer compounds that are coming on the scene?
Yeah, so there are, you know, a few, you know, KRAS inhibitors. You know, some of you may have heard of those that specifically are targeting the mutation, the G12C mutation. Unfortunately, that mutation is not at all common in pancreatic cancer. It's much more common in lung, and to a lesser extent in colon cancer. But it doesn't happen really, you know, much at all in pancreatic disease. And so the concern has been that that the other mutations that do happen in pancreatic cancer are more difficult to target. That being said, there are now two companies, Mirati and Revolution Medicine, that have KRAS G12D specific compounds that really show, you know, promising results, you know, in tumor cells and even in mouse models. So that's very exciting because we haven't had drugs that with those properties. But as you all know, you know, many drugs that, you know, look promising in a mouse don't make it all the way to the human setting. And those that do make it to the human setting may not, you know, may not function all that well, or there may be resistance mechanisms. So there's still a long way to go, but those drugs are pretty exciting because we haven't had anything like that until now.
Thank you. Dr. Ciolis, what are you most excited about in terms of research or your own research, that something that's about to be discovered or go into trials? What excites you as a researcher?
Thanks so much for that question, Dr. Ocean. I do think I agree with Dr. Chenwani. There is a lot of excitement over the potential for drugging KRAS, which people have been working on for, I don't know, 30 years at least. And it's such a major protein that's causative for pancreatic cancer. And so I think there's great potential, and we're all anxiously awaiting to see the results of what may be when, you know, when they put these actual drugs in humans and what's going to happen. In terms of the future, like the next 10 years, I am more excited about basically trying to figure out more personalized drug regimens for patients. Right now, a patient comes in with pancreatic cancer, and although we screen them for a handful of genetic predispositions or genetic diseases, most people get the same treatment. So I think understanding more about why certain drugs work well in certain patients. And we have these types of programs available at Cornell. For example, we have the ability to grow patient biopsies in 3D culture, which we call organoids. And so we have the ability to kind of screen for, are there certain drugs that patients may be more susceptible to, that kind of gives them more personalized medicine. So what I'm most excited about in the next 10 years is trying to understand why certain drugs work for certain people, and using that information to design personalized drug regimens for.
Me too. I really feel that the future is in this high throughput drug testing that we can do on organoids. The challenge has been a little bit about getting these organoids to grow. I know that you and a lot of other researchers are actively working on that. So that's exciting. Whenever we do biopsies, when we get a biopsy, for instance, when Dr. Sharaya does an endoscopic biopsy, she's able to give us some extra tissue through a biopsy that we can then try to grow, outside of the body, and then try to do drug testing on. And so that's definitely a procedure that's going to become more commonplace, I think, in the next few years. Not every place has the ability to do organoids, but we certainly do. And we're trying to do them on more and more patients, and to do them more often, so that, because the cancer changes with treatment. So we want to, see how the drugs change as well. Dr. Sharaya, tell me a little bit about the ctDNA that you were talking about, obtaining it from the portal system. How can that help someone who's going through therapy now?
So I think that's a great question, and just listening to everyone's talks is a sort of a very exciting field. And you've started, the oncology group at Cornell started just measuring circulating DNA as more for prognostic factors, or to see where the patient lies in terms of in response to treatment or in recurrence. And the thought is that these circulating tumor DNAs are a little bit of a higher quantity and higher concentration in the portal vein. And so if we can access that there, we can sort of predict recurrence or tumor a little earlier than when it goes into the periphery. So again, it's very early data, but maybe we can do it at the time of diagnosis. Sort of the portal vein is just there, and take a sample and see what we find.
Are you commonly taking those samples now, or it has to be through a study?
We're not taking it for, we access the portal vein for other reasons at the moment, but we could do it for circulating DNA for oncology now. But the original one, what I had presented, was through a study, but there's any reason for us not to do it if you're doing something else in the patient at the same time.
I have a question. One of the things that was mentioned for Francesca, what is the difference between hereditary and familial cancer?
Oh, it's a great question. So for the known hereditary causes, we can do genetic testing and do sequencing of the germline DNA, so DNA that somebody's born with, and identify a mutation in one of the genes that we know of to cause predispositions to cancers. But then most of the time that comes back negative. And so then you look at a family history and you see that somebody had pancreas cancer younger than you expect, or they had pancreas cancer and their parent had pancreas cancer, or there's a bunch of pancreas cancer running through a family, or other cancers that you think to be associated. So the way I like to explain it is, even though there's not one clear, very significant mutation that's causing a higher risk for cancer in this family that we know of yet, families share smaller parts of their DNA that we call SNPs, that each one might cause another 1% increased risk for cancer. So it's almost impossible to test people for them now without, it's hard to identify each SNP, but families share congregations of SNPs. Families also share environment, diet, lifestyle. So even though there's not a known mutation that's running through the family to cause a significantly increased risk for cancers, you see these clusters of cancers in families anyway. And our thinking is that the reason why their cancer is familial is because they share these DNA, these SNPs, their lifestyles, their environment, their diets, things like that.
Thank you.
Thank you.
So there's a question from the audience. Here it is. It says, do pancreatic cysts or pancreatitis increase the risk of developing cancer? Dr. Sharaya.
That's a great question. And we often get referred patients with pancreatic cysts, and about 15% of patients who have imaging done for some other reason, let's say they go to the ER with abdominal pain or something like that, they end up having a CAT scan or an MRI, and they end up having a pancreatic cyst. So our job is to determine what type of cyst it is and if it has an increased risk of progression into cancer. And there are two different types of cysts that produce fluid that's watery, and cysts that produce mucin. And it's the ones that produce mucin or mucus. Those are two different subtypes. They can be either what's called an IPMN or an MCN, and those have a higher risk of cancer. So those are people that we watch them in our program, which is a joint program between oncology, surgery, and us, where they get yearly or sometimes every 6 months surveillance with an MRI and then an endoscopic ultrasound. And a very new study that was just published recently also showed sort of following patients who have a family history as well, can increase detection for early pancreatic cancer. So if you have a cyst, we encourage you to be part of a program that follows your cysts regularly, or if you have a family history as well.
That's great. So if someone's found to have a cyst and they don't have a family history of pancreatic cancer, do we want to tell them to follow with a GI to get these regular tests?
Yeah, generally. I mean, if we can, at the type, depending on the size of the cyst, we would usually do an endoscopy, endoscopic ultrasound, and take a fluid sample from the cyst to sort of determine what type of cyst it is. We can also send it for certain markers that give us prognostic factors as to whether it would be more likely or less likely to turn into cancer. But any patient who has a cyst should be followed up by a gastroenterologist at least, to sort of have good follow-up to determine whether or not they will progress to cancer later on.
I have not heard of a smart MRI before, Dr. Sharaya. What would that do?
It's a smart MRI. No, it's our radiation oncologist colleagues. They basically have gone from, so the reason we used to do fiducials is because radiation would be sort of very, very broad, and you could get damage to the surrounding structures with radiation. And even though we target very specifically, like let's say the pancreatic cancer itself, you still can have damage to the surrounding organs. So fiducials decrease that risk. But now there's a smart MRI, which even targets the pancreatic cancer in 3D very, very precisely. And so then after that, the radiation is just targeted into those specific places. And I think we're one of, Dr. Eng told me this, and I can't remember, I think we're one of 3 centers or 2 centers in the country that have it. And so the gel therapy that I spoke about might be something that we could utilize later on, because what we've noticed from our like the history from prostate cancer is that as much as you target therapy, no matter what, you'll still have some sort of damage to the surrounding structures. And we see that with duodenal ulcers or sometimes stricturing that can happen in the GI tract from radiation. And so maybe the theory is that if you can inject some sort of gel around the duodenal wall, which you can do via endoscopic ultrasound, that could mitigate the risk that you get from radiation.
Oh, that's great. That would be wonderful, because it's not a common complication to get those things, but it can happen and cause discomfort or pain for the patient. So it's good that people are looking into ways to prevent that. The MRI Linac machine that we have here, one of my patients told me that it was like being in a video game and getting radiation therapy, because he was awake and he was able to watch the machine, the MRI machine, go up and down while he's breathing. And he saw that the beams were following the pancreas as it moved in the body during his breaths. And it was so targeted that he saw the rays, they were targeted towards his pancreas, and he could see them change and go up and down as it was breathing. And he said he felt like he was it was like his own video game that was targeting his cancer. That's how he described it. It was fascinating to him. So the technology to target things so specifically is really, really improving now. Well, I just want to thank all the panelists and thank Carlos and Malky for joining us today, and all the participants. We had this webinar in honor of November being Pancreatic Cancer Awareness Month. If you have any questions, feel free to reach out to us. And we're a very strong team here treating our patients with pancreatic cancer. And we are very much looking forward to advancements coming out. And we thank you all again for your time tonight. Thank you.